Hi, I am Mandy Irby, and I'm here with Maggie Runyon and Paula Richards as well. And we are all three co-founders of the Trauma Informed Birth Nurse Program. We're all bedside nurses, in addition to other specialties such as nurse educators, A1 educator, parent educator, entrepreneurs, nonprofit founders. And we were all three so overwhelmed and frustrated by feelings of isolation in making improvements to birth outcomes. We felt swimming upstream, fighting uphill. These were almost universal when we looked outside of our own units among L&D nurses all over the US. We thought there has to be a better way. So we're here for trauma-informed, curious nurses. We want to leave you with this quick video with a solid understanding of what trauma-informed care is and isn't, and some actionable steps at the end you can do immediately to move forward toward this model of care. We're going to do that by reviewing some common myths around trauma-informed care. We as nurses can't change collectively unless we know we're all going in the same direction together. Curious but not okay with one more fix? We did the fixes too. We did the learning, the communication training, the interprofessional collaborations, the committees. This is not one more fix. We know you're overwhelmed, confused by trauma buzzwords, perhaps, zero capacity for more changes. This isn't it. Also, a lot of nurses are feeling, I don't have the power to make this big of a change. It runs deep, systems deep. We deeply believe that nurses are uniquely positioned to make changes at the individual level, well within our scope of practice, that have ripple effects for generations, forward and backward. Now you're curious or you're questioning my sanity. Improvements need to be sustainable. Again, we know that your plate is full. This is not that. This is our definition of trauma-informed care. Again, with the buzzwords, we want to be all on the same page. Trauma-informed care is one element of organizational change that prioritizes the individual as the leader of their own health and recognizes how person-centered care shifts unhealthy power dynamics to mitigate the potential for trauma found in each care interaction. When you hear that, how does that definition resonate with your own understanding of trauma-informed care? And quickly, trauma, the response to a deeply distressing or disturbing event. Very simple, the simplest definition. There are big T's and little t traumas. And essentially, trauma is something that overwhelms an individual's ability to cope. It's very individual, causes feelings of helplessness, diminishes their sense of self, their ability to feel the full range of emotions and experiences. Think loss of control, betrayal, abuse of power, helplessness, pain, confusion, and/or loss. And it's important to remember that it's about their subjective experience and us believing them. Now, we may not know about everybody's past trauma, and that's fine. We're not here to diagnose nor categorize anybody's trauma.
Yeah, just as Mandy said, it's not our job to diagnose, to understand everything about someone. But so often we have that pressure put on us when we are over here in this helper nurse role. We either have been kind of pinpointed as the handmaiden or the hero of the situation. And, both of those really take us away from truly connecting with our patients. Trauma-informed care is a way for us to more confidently step into that advocate nurse role, where we are centering our patient while also prioritizing their safety, autonomy, and ensuring informed decision-making. And, all of these pieces are things that we want to be doing each and every day. But so many times there are myths, misconceptions about person-centered care and about trauma-informed care. And we want to break some of those down for you. So first thing is our awareness around it. So often we have been taught that trauma-informed care is only for those people over there, right? We think of folks who've experienced sexual assault, medical trauma like a motor vehicle accident or a hemorrhage, those who are in an intimate partner violence relationship, someone who's lost their partner or has lost a pregnancy, anyone who discloses specifically that they have a history of trauma and that they need this type of specialized care. However, the reality is it's so much easier than that. Trauma-informed care is for every person, for every reason, for every birth. When we get away from that feeling of needing to diagnose and to dissect someone's story and instead shift our standard of care to being one of trauma-informed care for each person, it's actually so much easier for us. I know, but there are a couple challenging colleagues that you work with, and those are the ones that cause the trauma. I know who you're talking about. We all have those people we work with, the, old school providers who are stuck in the mud, the nurse ratchets of the unit. We also sometimes think that trauma is something that happened before the medical facility. And so it's not really anything that we can shift or prevent or minimize. And luckily, that's not the truth. The painful reality is that 45% of birthing people identify their birth as traumatic, which means that way more of us play a role than we like to think in how folks experience their birth. So we can take a moment to think about that, to integrate that, because it is hard to sit with that. However, it also means that we have so much power to step into as we work to provide better care. And then the other piece of it is that so often we understand, like, okay, got it. Trauma is real. It affects a lot of our patients, but you're detached and it's your job to be that way. A lot of times nurses who are affected by trauma are seen as, as weak, as only those who are unstable, can't handle the rigors of nursing, have mental health issues themselves, people who had their own traumatic births or pregnancies that they are kind of carrying on into that space. And we also know that right now, about 35% of birth nurses experience secondary trauma stress. So that means that about 1 in 3 of us are walking around carrying these heavy burdens from the births that we're part of. And we need this new standard that allows us to support our patients in the best way possible and to also support our own well-being and those of our colleagues.
As promised, we have actions that you can take immediately to start to shift into this new standard of care, even beginning in your next shift. And I want you to pause. These are things that you have at times done with your patients. They may look simple, but I'll explain. Imperfect action, that is starting to try and implement these new actions, these interventions that may not feel new to you. And even if it's imperfect, I think you'll discover more about your patient. You'll discover more about yourself. Perhaps you're not doing any of these super consistently, or perhaps you're not doing some of these at all. So we're also going to categorize some of them into ways that we can reduce the incidence of trauma or re-traumatization within our patients' healthcare experience and experience with us. We're trying to increase connection with them as a way to minimize their risk for trauma. We can group these by increasing control, trust, and presence. So let's take a look at some examples. The myth is that trauma-informed care is too hard. Is this just one more fix? How can I possibly know what everybody needs from me? How can I know all about their trauma? I'm tiptoeing around, not hurting them anymore now that you have a little bit more understanding about trauma-informed care. I encourage you to think, if you don't understand why they're making responses that they're making or asking questions or making decisions that they're making, consider, instead of what's wrong with you, what happened to them, as a way to tune into ways that you can discover more connection with that person in control, trust, and presence. We've been taught that these actions and these foundations of nursing are nice to have and not need to have. These are not prioritized in our care. However, we often do practice this way. Showing respect. That's what we try to do with our patients. Consider reaching out of our own culture, getting curious in ways that are respectful to them, asking what name they want to go by instead of calling them by their first name or their last name, or even pet names or gendered salutations. Sharing your name with them and allowing them to see your badge consistently. Ask before touching their body every time. This consistency is going to increase their sense of control and their trust with you, improving their connection with you. And again, informed consent in all ways. Consider there might be times that you're not including informed consent or informed choice in every interaction. How can you increase that frequency in your care interactions? Again, control, trust, and presence. We're physically centering the patient in their space, physically showing that you respect their space, and continuously affirming that they are central and leaders in their own healthcare. When it's consistent, it's affirming. When it's not, it's confusing to them, which degrades trust and connection. In those cases, they might feel like they're on the conveyor belt of healthcare, and those are the times that we feel like we're the robots of healthcare. In a way to shift out of that mindset, think about increasing connection, control, trust, and presence.
Now what, huh? We know from having countless conversations with nurses across the US that trauma-informed care sounds like a great idea, right? And so many of these pieces that Mandy just went over are like, yeah, okay, I can do that. I can do that piece. But we know it's not that easy. You may be thinking that you have these policies that limit care and make change really hard. You're grappling with your own biases as you're thinking back about the kind of care you've been providing and whether it really meets the standard that you want to have set for your care. You're worried about getting pushed back, right? Your coworkers, maybe your management, they just don't get it. And it sounds good, but it's not all what you've learned before. Or you're feeling pretty low on the ladder, you're feeling powerless to make change. And we understand this is not something that shifts in a day, okay? This is reimagining our practice and recentering ourselves on truly the art of nursing and where we started from. So We want to offer you more than what we know was this very quick video that started to dive into some of this. We want to go deeper, walk step by step through what it really means to uncover advocacy, to listen to birthing people, to center parents in our education, to investigate obstetrical mistreatment, the violence that occurs every day in our specialty, to learn how to leverage our power and privilege as we step into this advocate nurse role, to defend nursing practice, to work through a lot of the issues we have as we think about risk and liability, and to live trauma aware, both professionally with our patients, with our colleagues, but also as we carry this into our personal lives. And we truly believe that community is central to that. So we want to offer peer support as you work to relearn, unlearn, consider what birth care can look like for you, for your community. And we do that through the Trauma Informed Birth Nurse Program. We would love to connect more deeply with you as you figure out how we can partner together to learn and grow. So you are welcome to reach out to Mandy, Paula, or myself. Our emails are there and also our Instagram handles. That handout QR code will leave you to just a couple of the basic things we've gone through here as you reflect on this information. And then we also offer you to check out further learning with us. Thank you.